All right, guys, what is up? I'm super excited about the topic for tonight because these are only like 30-minute long little classes that I give. I really wanted to go into more detail with this one, but I'm gonna kind of get through the slides and then open it up for any questions that you might have. And then if you have additional questions, I want you to just like drop them in the comments to the chat, or you can just like message them to me so that I can make sure that I'm going into this stuff a little bit in more detail in the future. Let's see here. I was gonna pin myself. There we go. Cool. Yeah. So that, we can dive into things that you guys are really actually excited about and want to know more about, and that this stuff is really valuable for you. So this is going to just kind of be a broad overview. And I titled this class Five Health Risks That Don't Show Up on Your Annual Physical. Wah, wah, wah. So let me get a screen share going of the slide deck. And we've got screen two fired up. All right, cool. Um, Ashley, can you let me know if you can see the slides? Because I'm not sure.
Yeah, I could see
Okay,
them.
perfect.
Yeah.
Beautiful. I'm never sure. I always want to be sure. So we'll present these things. So five health risks that don't show up on your annual physical. And then we're gonna like get into detail and well into somewhat of like a smaller detail of each of these five things. And like I said, let me know if you have any further questions so that we can just expand on this stuff in the next coming year. Okay, so why normal labs can be misleading, right? So all of you probably, hopefully, go to an annual exam with your primary care physician and they like do this whole panel of labs, and then you go in there and they kind of take like a brief history, or maybe they don't, and they're just like, oh, at least, up until like you're 35, 36, 37, 38, they're like, oh, everything looks good. Any concerns? And you're like, nah, no, not really. And then they just kind of let you go. Or maybe they say like, hey, your cholesterol's a little bit higher than it was last time. And then they say this, we should keep an eye on that, right? But there's no actual intervention going on. So the reason for some of this is our medical system is really created to be um, diagnosing disease. So it can often be reactive and not proactive when it comes to capturing early disease process and reversing it like at the onset as opposed like at the onset of early disease as opposed to the onset of actual disease. Many guidelines allow risk factors to rise until disease thresholds are actually met before intervention. And lifestyle change is frequently delayed or underemphasized until patients are dangerously close to disease thresholds or already meet the criteria for disease thresholds. And meanwhile, your physiology continues to change year after year, right? So as you're getting older, these guidelines many times aren't changing rapidly and things aren't being captured early before you actually have full-blown disease. So this is what we're going to talk about tonight. We're going to obviously go through each of the five health risks that they're not even measuring in primary care when you go to some of these appointments that can actually help us prevent disease across the board. So you might be like, well, why don't we do this? The funny thing is, when we do police and firefighters physical exams in this other job that I have, which I'm going to do tomorrow for one day, we do actually measure most of this stuff. And I'm not really sure why it hasn't become kind of a widespread thing where we're just doing it for each individual. Um, yeah, I think it may be because of the cost associated, the length of time of testing potentially, but we just don't do this for the general population. So in each of those five buckets that I'm going to go over today, we're going to talk about the health risks that are associated with these 5 things if they decline before we capture them as an issue. We're going to talk about what doctors don't often measure, which is each of these 5 things, and why we are waiting too long to address them, and early warning signs that you can pay attention to in each of these 5 categories so that you can have some red flags in your mind of what you need to be watching for, and then what can actually help protect you as well. And that'll just be basically the opposite of all of these things. So we'll get into each of the five things we need to be watching for that you are not getting measured in your primary care annual visit. Risk number one, muscle loss. This is also known as sarcopenia in the medical community. And muscle mass is generally not measured, right? Even when we are measuring bone mineral density, which we'll get into that one, which is one of actually the 5 risks we're going to go over. Even when we are measuring bone mineral density, we are not really looking at muscle mass in conjunction with that, even though the modality of imaging that we're looking at bone mineral density for can actually measure muscle mass. I've not heard many physicians talk about muscle mass even going over DEXA scans. So muscle loss begins in your 30s and accelerates, can happen even faster with undereating, stress, and inactivity. Again, not assessed at annual visits. And muscle is not, what is it? Muscle is not muscle. That's funny. Muscle is not just for aesthetics, right? It's actually preventative medicine. And you might have noticed that we put a really strong emphasis on building muscle in this program. And this is exactly why, because muscle is preventative medicine. Additionally, things that can accelerate muscle loss is menopause. Losing estrogen when we're in our 40s and 50s will accelerate muscle loss if we do nothing about it. And low muscle mass is a strong predictor of lifetime fall risk, fractures from low bone mineral density, insulin resistance, and loss of independence with aging. Now, on the rest of these 5, you'll see me write in these predictors increased all-cause mortality. That would also be true for muscle mass. I just didn't have a 5th slot to put it in there, and I was trying to stick with 4 to keep things simple. But you will have increased all-cause mortality when muscle mass goes down. So the lower it is, the more likely you are to die for any cause as you age, which is kind of crazy when you think about it. So things to watch out for since your doctor's not going to measure this. I'm here. Hi, I'm going to help you think about this at least, even though we can't per se measure it. We can get some good ideas with some of these equations that I run for you guys. But what to watch out for even after maybe you're not working with me anymore is like, hey, I'm getting weaker year over year. I am starting to get these injuries that I normally wouldn't be injured from this activity, right? From normal activities. And then fatigue just from daily tasks, or unable to do certain things that you used to be able to do around the house. Even just squatting down and standing back up, getting up off the ground can become an issue too with lower leg strength. And then even just getting out of a chair can become an issue too if you let this stuff go too far. So let that kind of be a barometer for you. Be like, oh no, I'm getting weaker. These other things are happening. I should probably get back into the gym and do some of those things that Stevie taught me back in 2025 and 2026. Risk number 2, declining cardiorespiratory fitness. Specifically here, the measurement we're looking at could be VO2 max, right? We could do VO2 max testing in primary care. We certainly do VO2 max testing with all of these police and fire physicals that we do. And we do that for them every single year. But in primary care, this is just not done. It is time consuming for sure. So it would probably be harder to implement, but it is important, even though it is not measured in the general population, because we actually lose about 10% of our VO2 max. So that's like the highest respiration rate that we can kind of hit or exercise at. We lose 10% of this every single decade if we're not training it specifically. And again, rarely measured in clinical care, and you can absolutely have good labs and poor cardiorespiratory fitness. Yes, you can. So this is missed quite frequently. Fitness should be a vital sign, and in primary care, it's largely ignored and not even really discussed in most annual physicals. Low cardiorespiratory fitness is a strong predictor of all-cause mortality. You're going to see this in pretty much every other one. Cardiovascular disease and death from cardiovascular disease, so heart attack and stroke. Fatigue and stress tolerance with activity, right? So what you should be watching out for, since you're not getting this measured at your primary care visit, is like, oh my gosh, I'm getting winded much faster than I used to. I like am getting winded just walking up a flight of stairs, or you're avoiding these things or sustained efforts because it's uncomfortable for you. And then just exercise tolerance in general shrinking. That should be, again, your barometer for being like, okay, I need to do something about this. Um, and as far as like, muscle mass, we know how to do that, right? I'm training you guys for muscle mass like pretty aggressively just because we are all in our upper 30s, 40s, and 50s, and 70s. We have people like spread from 30s to 70s in this group. And muscle mass is going to be the number one most important thing to do initially. And then some of you have kind of graduated into some VO2 max intervals. And eventually, that's my goal for all of you, is to graduate you into like a split of both of these things. So interval training is the best way to train this. And that's going to be, I would start with 30 seconds hard push on with like a bike or anything. You could even do this outside, like 30 seconds all out sprint, and then rest as long as you need to. So you can do that all out effort again for 30 more seconds, 4 to 5 times. And that's a good beginning point. But the best thing you can do is work up to 4 and 4. So 4 on all out effort, 4 rest, and then do that again 4 to 5 times. That is the most well-studied kind of protocol for VO2 max improvements. But definitely starting with a 30-second protocol is what I would recommend for most of you. So risk number 3, metabolic dysfunction. Before labs change, so we're looking at cholesterol, high cholesterol, we're looking at diabetes here, right? So waiting for abnormal labs are waiting for an A1C to be over or at 6.5, or cholesterol to like crack through those thresholds of hyperlipidemia or high cholesterol is not prevention, right? So we definitely want to capture these things as they start to creep up. And I see clinicians over and over and over again just being like, oh, what did I say? We'll keep an eye on that. But it's like, no, we should do something about this now, because it's going to just get harder and harder for us to reverse this as it continues to elevate. So blood sugar and cholesterol are allowed to creep dangerously close to abnormal range before intervention is even discussed, and even lifestyle changes are delayed or underprescribed by most primary care providers. And then another caveat, even if your primary care provider does prescribe these lifestyle changes, they don't really understand targeted approaches to be able to help you lower those thresholds of lab values with these lifestyle modifications. So, 1, metabolic dysfunction develops years before diagnosis. Metabolic dysfunction is something we absolutely need to capture early as it's slowly starting to creep up, and try to reverse immediately through the things you guys are already doing in this program. And then number 2, when we capture these early, they are much, much easier to reverse. And number 3, late changes are much harder to unwind. So waiting until you crack that disease threshold is not always, and most often, not the right answer. Cholesterol is a little bit of kind of like an interesting loophole here, because many, many people actually just have this genetic predisposition to having higher cholesterol, which means just like, hey, my mom had this, my dad had this, their parents had this. We need to probably just treat that much earlier in people who might have a genetic predisposition for this. Cholesterol can be much more difficult to move the needle on with especially diet, but exercise is the number one best intervention that we can use long term for all of this stuff. And really, mostly, you guessed it, muscle mass. And we've talked about that before too. So watch for these things. Your cholesterol starting to creep up year over year. Your energy crashing totally after meals, especially. And then weight gain despite consistent habit change and increased hunger or cravings. So all of these things can indicate or be kind of like a yellow light for diabetes or other high cholesterol issues. Okay, number 4, bone density loss. We've finally gotten to it. Osteopenia. So osteopenia is actually bone loss before you actually hit the threshold marker of osteoporosis. Bone density declines with age and hormonal shifts. And I've learned this, I think, just in the past year. And this is kind of crazy, but osteoporosis and osteopenia are actually diseases that we start developing in childhood. Most of our bone mineral density is laid down and solidified at its highest baseline by the time we're like freaking 23 years old. So if you already don't have a higher baseline, there's not a ton you can do to move the needle about that right now. All we need to do is kind of scrap to keep the bone density that you do already have. Just kind of like muscle mass, bone density is going to decline with age and hormonal shifts in menopause. And it's especially, like I said, very vulnerable in perimenopause when that estrogen is starting to decline. And we often actually don't catch this in many women, especially if they're kind of like osteoporotic or have lower bone density before the age of 65. So sometimes we don't catch this until they've already sustained a fracture because guidelines don't recommend DEXA scans to measure bone mineral density actually until we're 65. I actually had an old client who we were training, man, training hard. We were lifting weights, we were lifting heavy, we were lifting with reps in reserve, and she was doing amazing. She had just turned 65, got her first DEXA scan. Boom, osteoporosis. Because she hadn't had estrogen on boards and she was like 20, right? So it's crazy because most women are completely through menopause by the age of 50, and we aren't doing DEXA scans until 65. And we are talking about having the highest amount of bone mineral density that we'll ever have when we're about 23. But we're not measuring women because we're at way more risk because of losing estrogen. We're not measuring women between age 23 and 65 from the highest to where we might already be at some of the lowest we're ever going to be. There's nothing in between. So that's kind of wild. There's a lot of DEXA places popping up that you can pay like $100 or something to go get a DEXA scan. I might recommend that, like just to go get a baseline before you're 65. Let's see where you're at and see, like what interventions we need to do. Basically, the interventions are all going to be the same, and we're doing them right now in this program. Bones need stimulus early, not sympathy later. Okay, I love that line because when we diagnose someone with osteoporosis, we're immediately like, oh no, we have to be careful with you. It's fragile. But like, really, this person needs some sort of supervised heavy lifting, right? Someone who can prescribe, like, hey, we need to do heavy 5x5s is one of the studies that was done, or the kind of style of training that you guys are doing. With people over 65, I usually don't train reps in reserve or to failure because it's just not necessary. It's just like really taxing on the central nervous system and not necessary. But like to 1 to 2 reps in reserve is usually fine. And that's going to really, really help that stimulus no matter what age you are and can help protect you, even if it might not improve your DEXA numbers, it can help that hard cortical bone that's on the outside of your bone and improve the strength of your bones. So low bone density is a strong predictor of death-related falls. That's scary, right? fragility fractures, so fractures with smaller injuries that might not have affected you when you were younger, loss of mobility and independence due to chronic pain in those vertebral columns kind of collapsing down on each other, and fragility and muscle loss. So what do you watch out for? What I would do if I were you is like, hey, let's just make sure that we are doing resistance training for the rest of our lives and that we maybe are measuring some vitamin D statuses and making sure that that is in the appropriate range, which I would say is probably between like 60 and 90 when you get those drawn. So what to watch out for: fear of impact lifting, of impact or lifting because you're having pain, increased like shin splints stuff with just like low impact stuff, or just walking. Long-term calorie restriction, that's going to be a red flag for like, hey, is this person's bone mineral density good or bad? And then longer periods of being sedentary, especially after the age of 40, can be something that you're going to need to watch out for and be like, hey, maybe I need to start lifting some weights again. And the last one, risk number 5, nervous system overload. Chronic stress is rarely measured in clinical care. In California, I actually think this is getting better, and Ashley might know a lot more about this, but decades of research show that the impacts of this chronic stress, of any kind of chronic stress, is absolutely profound. And the adverse childhood experience study demonstrates that cumulative stress exposure, especially early in life, is strongly associated with increased risk of all chronic diseases, mental health conditions, and early mortality later in adulthood. I think that at least all pediatricians have the ACE study on their intake forms and their screenings before each patient is seen. And I'm not sure about adults. I think it's a possibility though. But I think it's the only state that actually implements this stuff. So these stress loads, even in childhood or in early adulthood, they don't just appear or disappear over time. They actually shape your nervous system regulation. They can affect everything, literally everything: inflammation, recovery capacity. And when stress remains unaddressed, that's the key thing right there, is unaddressed, then like recovery is treated as optional. The body stays in a proactive and a protective state, which means you're going to be storing fat. It's going to be harder for you to adapt and overcome illness or injury across every system. Okay. So again, you're seeing here, what if we don't manage this stress, if this stress is left unchecked, what am I at higher risk for? Boom, boom. All-cause mortality, right? It's on every single one of them. Anxiety and depression, metabolic dysfunction. So you're more likely to be overweight, become obese, or have a harder time losing that weight because your body is just storing that fat instead of feeling safe so that it can let go of it. And immune dysregulation and chronic inflammation. So what should you watch out for? Well, you know your own history, right? You can even Google the ACE questionnaire. Just put ACE questionnaire and you can take that and it'll tell you what your risk is from childhood experience. Poor sleep, high reactivity, feeling wired but tired, and difficulty being consistent with pretty much anything in your life. These might be red flags that you need to, like, hey, go talk to somebody. That's okay. Like get a therapist involved, get some kind of intervention going on, like if you want to go join a meditation class, all these kinds of things to be able to down regulate you and help you out. So, critical reality check, and this is kind of just an overview slide here. Guidelines are designed for populations, not individuals, right? So we get all of our numbers in the, like, if you go to LabCorp or whatever, and they're like, this is the normal range. That normal range was created from basically a data bank of a bunch of sick people, right? So we have these normal ranges, and these are not optimal ranges necessarily. And it's just based on populations-based data. Prevention is under incentivized in medicine in general. So any kind of hospital system, any kind of clinic, they're held to certain standards, and prevention is not necessarily listed high on some of these standards. Lifestyle medicine is, it says often underutilized, but I'd say very often underutilized and not even educated. We're not really educated on some of that, most of that stuff, on how to implement lifestyle medicine in any kind of medical training. And political beliefs, this one like is crazy, guys, but like political beliefs and biases from your physician or your provider can absolutely influence care. So that's something that you probably never thought about that you might need to watch out for. I've definitely seen providers practice kind of some fringe medicine, and these are just people who work in normal clinics. Like I've seen this happen, like more than I can probably count. So just make sure that you're advocating for yourself, right? Best practices don't always get applied consistently, which is why self-advocacy matters. And it's probably one of my bigger goals in this program is to teach you guys hopefully what to look out for and what you need to be on the lookout for, like what is the standard of care. And you're always welcome to, if you have appointments or anything like that, or if you're like, hey, this was kind of funny, to like reach out to me and run it by me, and I would be more than happy to help you out with that stuff. That's part of what you get here when you're with me. Okay. So preventative medicine here in this context, in every context, is building muscle, maintaining fitness, addressing trends early on, right? When those numbers start creeping early, as opposed to when they're above threshold and then treating them, supporting metabolism and protecting recovery. It is not just waiting, minimizing concerns or accepting minimized concerns from whoever is taking care of you, and only reacting after disease metrics have been established or decline has already started. Cool. So you don't need to panic. You don't need to optimize everything, but you just need to know what to look out for, pay attention earlier, intervene sooner, continue to do the things, the groundwork that we've laid in this program over time, and you're going to be better off than probably 90% of the population. And this is going to help you protect your capacity moving into the next decades intentionally. So I want you to kind of think about this as homework. Which of these 5 risks are you actively addressing right now? And which one have you been assuming, or which ones are you surprised about because you were assuming, oh, someone else will catch this and let me know what to do if I'm in danger? And then drop that down in the comments, and let me know. I want to hear about you guys. I want to have a good conversation about this. So Ashley's here. Do you have any questions, Ash?
Yeah, maybe I was curious about the sarcopenia one, but does that just like slow down the process if we're actively muscle building, or it still
Yeah.
happens? Or because I feel
Well, so
like I'm
yeah, so we
lifting more
yeah,
than
we
I'm
can
actually are.
predict this kind of over time. I didn't put the stats on here, but I think it's similar to the bone loss statistics, or I'm sorry,
Mm-hmm.
it's not the bone loss, like it's similar to the VO2 max
Mm-hmm.
statistics, where we'll lose like 5 to 10% of our muscle mass each decade after 30 if we're not doing anything about it, right? The
Mm-hmm.
coolest thing about muscle is we can actually build muscle really, really pretty well at any age. But there's a caveat here. We can build muscle at any age, but muscle takes a lot of time to build.
Right.
Once we've kind of capitalized on that first initial big gain that you might have right when you first start lifting, um, it becomes a lot harder. It's like incrementally harder to gain more over time, which is why and I think I say this a lot, but like when you see these people like on Mr. Olympia or whatever, like these big bodybuilders that have like huge giant muscles, like these are people who have been training like you're training, right? Because you're on a really big RIR program. We're doing 4 days a week pretty consistently with you. They're training like that for like 10, 12, 15 years before they are that big. And most of that like wasn't just in the last year that they lifted, because it just gets harder and harder to get more after a certain point. Does that make
Mm.
sense?
Mm-hmm.
So that's why
Gotcha.
it's like, hey, the earlier you can start, the better, because we might gain 5 pounds of muscle the first year. That would be
Mm-hmm.
pretty good, like 5 to 8 pounds, and the first year would be pretty good. But then after that, it's going to be like maybe 7, maybe 6, maybe 5, and then after a certain amount of time, it's going to be like maybe I'm gonna get 3 more pounds of muscle in a year, maybe 2. It's just going to be harder. It takes a long time to build muscle. So that's the biggest takeaway here. Start early and
Mm-hmm.
lift often.
Lift often. Love it.
Yeah. Awesome. Any other questions?
Nope, that's all I have. Thank you. That was
Badass.
all
All
good to
right. You're
know.
welcome. Have such a good night. All
You
right, you
too.
guys. I'll see you guys later. Don't forget your check-ins tomorrow. Bye.